Welcome to our video on renal tubular acidosis. Let's get started. Before we dive into this lecture, let's start with the introduction. Renal tubular acidosis, or RTA, is a disorder of ion channels and transporters of renal tubules. Renal function is typically preserved, and this is a very important feature that separates it from other kidney conditions that cause metabolic acidosis, such as chronic kidney disease. RTA causes a normal anion gap metabolic acidosis. Remember the common mnemonic HARD-AS to recall the causes of normal anion gap metabolic acidosis, where H stands for hyperalimentation, A stands for Addison disease, R stands for renal tubular acidosis, D stands for diarrhea, A stands for acetazolamide, S for spironolactone, and the final S stands for saline infusion. The causes of RTA can be either genetic or acquired, and it can be divided into four types 1 through 4. Before we get into the specific types, let's quickly review two important concepts: serum anion gap and urine anion gap. Let's start with serum anion gap. Serum anion gap is the difference between the unmeasured concentrations of cations and anions in the blood. It's calculated as serum anion gap equals sodium minus chloride plus bicarb. Although potassium is a cation, it's usually ignored in this formula because the concentration of potassium is very low and doesn't change the value much. The normal serum anion gap is between 6 to 12. A high anion gap usually occurs when there are unmeasured organic acids such as lactic acid, oxalic acid, and keto acids. All right, now let's move on to urine anion gap. Urine anion gap, like the plasma anion gap, involves the measurement of ions but in the urine. It's the difference between the measurable cations and measurable anions in the urine, and is calculated as the urine anion gap equals the concentration of sodium in the urine plus the concentration of potassium in the urine minus the concentration of chloride in the urine. It's an indirect assessment of ammonium ion excretion. It's used in cases of metabolic acidosis and to differentiate between renal and gastrointestinal causes of metabolic acidosis. The ammonium ion is a positively charged ion, so it forms when a hydrogen ion combines with an ammonia molecule. The excretion of ammonium in the urine causes a fall in the urine anion gap value. So, a positive urine anion gap is seen when the kidney fails to excrete ammonium ions, and a negative urine anion gap when there is increased excretion of ammonium ions. It's important to understand how these are calculated for a better understanding of the different types of RTA. All right, let's try a question. An arterial blood gas report of a 25-year-old female shows a pH of 7.3, a PaCO2 of 36, and a bicarb of 20. Her serum electrolytes are a sodium of 140, a potassium of 3, and a chloride of 110. Urine sodium is 30, potassium is 10, and chloride is 20. Urine pH is 6. What can be a potential cause of the acid-base disturbance in this patient? All right, let's first find out what this patient's acid-base disturbance is. She has a low pH of 7.3, a normal PaCO2 of 36, and a low bicarb of 20, indicating a metabolic acidosis. Now the question is whether this is a normal anion gap or high anion gap metabolic acidosis. For this, we subtract the sum of chloride and bicarbonate levels from sodium levels, which in this case is 10. Recall that the normal serum anion gap is between 6 to 12. So we know that she has a normal anion gap metabolic acidosis, and this is commonly caused by diarrhea and renal tubular acidosis. The way we differentiate these two conditions is by calculating the urine anion gap. To calculate this, we subtract the urine chloride levels from the sum of the urine sodium and potassium levels, which in this case is 20. A positive urine anion gap is commonly seen in type 1, 3, and 4 renal tubular acidosis, while a negative urine anion gap is seen in diarrhea and type 2 renal tubular acidosis. Additionally, since this patient has hypokalemia rather than hyperkalemia, this will be a type 1 RTA. We'll discuss how to differentiate between the types of RTAs later in this lecture. All right, so here's our overview slide, and as you can see, we'll be discussing the 4 types of RTAs. Let's begin with distal or type 1 RTA. For each of these topics, we'll be discussing the definition, etiology, pathophysiology, clinical presentation, diagnosis, and treatment. So let's start with the definition of type 1 RTA. Type 1 RTA is also known as distal renal tubular acidosis and is defined as a defect in the distal convoluted tubular transport system, resulting in an inability to secrete hydrogen ions into the tubules. Most cases are idiopathic or could be due to genetic defects, as in familial type 1 RTA. Adults commonly develop idiopathic RTA, whereas genetic defects are common in the younger population involving genetic mutations in exchanger or transporter genes. Nephrotoxic medications such as amphotericin, ifosfamide lithium, and NSAIDs can also cause RTA. Among individuals who sniff glue, is also one of the well-known causes of distal RTA in drug abusers. Autoimmune disorders like systemic lupus erythematosus, rheumatoid arthritis, and Sjogren's syndrome can also cause type 1 RTA if the immune system attacks the distal tubules and compromises their function. Finally, conditions causing hypercalciuria like hyperparathyroidism, sarcoidosis, and excess vitamin D intake should also be kept in mind as possible etiologies. All right, let's use this image to discuss the pathophysiology of distal renal tubular acidosis. And we'd like to thank Amboss for our partnership with them and contributing this image so that we can explain this idea in more detail. Before we discuss the pathophysiology, let's review some of the normal physiology. There are two main cell types that we need to know: principal cells and intercalated cells. Principal cells are the site of action of aldosterone and are responsible for sodium and potassium regulation. And intercalated cells play a role in blood pH regulation. Looking closely at the type A intercalated cell, a proton is released into the tubular lumen through the hydrogen ATPase pump, and bicarbonate is reabsorbed. This normal physiology is altered in type 1 RTA, where the type A intercalated cells fail to secrete hydrogen ions into the tubular lumen. This leads to the retention of hydrogen ions within the tubular cells and a progressive backleak into the interstitium. Subsequently, bicarbonate is also lost through the tubular lumen in exchange for chloride ions. This results in hyperchloremic metabolic acidosis, which is a normal anion gap metabolic acidosis. The inability to acidify the urine explains the alkaline pH of the urine in type 1 RTA. Distal RTA is also characterized by hypokalemia. There are many theoretical explanations, but the most sensible one is a failure of the hydrogen-potassium ATPase, leading to a loss of potassium. Patients with distal RTA commonly present with symptoms of nephrolithiasis, such as colicky flank pain, hematuria, etc. There is an increased risk of calcium phosphate stone formation because calcium phosphate crystals precipitate in the alkaline urine. Growth failure can be seen in infants due to metabolic acidosis. And lastly, features of hypokalemia like muscle weakness and U-waves in an ECG are frequently present because the renal tubules fail to secrete hydrogen ions, leading to decreased potassium reabsorption. Here's a picture of an ECG showing a U-wave denoted by the black arrow. U-waves follow T-waves and represent the repolarization of Purkinje fibers. Some conditions that may show U-waves are hypokalemia, sinus bradycardia, and antiarrhythmic drugs like quinidine. The diagnosis of distal RTA should be suspected in patients with unexplained non-anion gap metabolic acidosis. Serum findings will be significant for hyperchloremia, hypokalemia, and low serum bicarbonate levels. An important finding to remember is that hypokalemia in distal RTA improves with alkaline therapy, in contrast to proximal RTA where hypokalemia worsens. Urine findings include hypercalciuria and a urine pH value of 5.5 or higher. The alkaline urine is seen due to decreased proximal bicarbonate reabsorption and the inability to acidify the urine. A positive urine anion gap is seen due to impaired ammonium ion excretion and decreased chloride ion in the urine. An ammonium chloride acidification test is the gold standard method to diagnose distal RTA. Ammonium chloride is administered orally to the patient, after which the urinary pH and serum bicarbonate levels are measured. Distal RTA can be diagnosed when the urine pH remains alkaline more than 5.3, even after the administration of ammonium chloride. This evaluates the potential of the distal tubules to secrete hydrogen ions. Finally, let's move on to treatment. Sodium bicarbonate, or sodium citrate, is administered to correct the metabolic acidosis. Potassium citrate is also administered in cases of persistent hypokalemia. All right, now let's move on to proximal renal tubular acidosis, or type 2 RTA. Similar to type 1 RTA, let's begin with the definition. Proximal RTA is a disorder of the proximal convoluted tubule causing impaired bicarbonate reabsorption. It can be further divided into two, an isolated form and a generalized form. Isolated proximal RTA is characterized by isolated impairment in bicarbonate reabsorption. The generalized form is known as Fanconi syndrome, and this is characterized by a generalized defect in the proximal convoluted tubules, leading to an impairment in reabsorption of not only bicarbonate, but also amino acids, glucose, phosphate, sodium, potassium, and uric acid. Now let's go through the etiologies of proximal RTA. First, we'll go through isolated proximal RTA. It can be idiopathic or may be associated with inherited genetic defects, such as familial type 2 RTA. Carbonic anhydrase inhibitors, such as acetazolamide, can induce type 2 RTA as well. Acetazolamide impairs proximal bicarbonate reabsorption without affecting the reabsorption of any other solutes. The etiology of Fanconi syndrome can be broken down into inherited and acquired causes. Some hereditary diseases include Wilson disease, galactosemia, tyrosinemia, stenosis, and type 1 glycogen storage diseases. Multiple myeloma and amyloidosis can also lead to this pathology by causing renal deposition of immunoglobulin light chains and amyloid proteins, respectively. Expired tetracyclines get converted into toxic metabolites that can also damage the proximal renal tubules. Other nephrotoxic drugs associated with Fanconi syndrome are ifosfamide, tenofovir, and cisplatin. Exposure to heavy metals like mercury, lead, and cadmium can also cause Fanconi syndrome. Finally, other causes include acute tubular necrosis, proximal nocturnal hemoglobinuria, and vitamin D deficiency. All right, here's this overview image again, and let's again review the relevant physiology. So in the proximal convoluted tubule, we can see that this is the primary site of reabsorption for amino acids and sodium. Within renal tubular cells, sodium is reabsorbed from the lumen along with glucose via SGL2 transporters, and then these molecules are transported into the interstitium. When this happens, a negative potential is generated on the luminal side that drives bicarbonate into the tubular cells through carbon dioxide diffusion. Inside the cell, carbon dioxide combines with water in the presence of carbonic anhydrase to give off bicarbonate, and this gets released into the interstitium via the sodium bicarbonate symporter. Now, when this mechanism is impaired, there is a failure of bicarbonate reabsorption, leading to features of proximal renal tubular acidosis. This includes metabolic acidosis due to lack of bicarbonate in the blood and acidic urine due to intact hydrogen secretion from intercalated cells in the distal tubules. All right, moving on to clinical presentation. Skeletal abnormalities occur due to hypophosphatemia and low calcitriol levels, as proximal convoluted tubular cells are responsible for the conversion of vitamin D to its active form. And this may manifest as rickets, short stature, osteomalacia, osteoporosis, and pathological fractures. These findings are more severe in Fanconi syndrome. Persistent hypokalemia can lead to muscle weakness and U waves seen on an ECG. And finally, patients can also present with polyuria and dehydration. This is a chest X-ray of a child with rickets. Notice the nodular prominences at the right costochondral junctions that are caused due to anterior rib expansion. This is known as rachitic rosary and could be one of the manifestations of hypophosphatemic rickets secondary to Fanconi syndrome. All right, moving on to the diagnosis. Serum findings include hyperchloremic metabolic acidosis. Recall that RTAs result in a normal anion gap metabolic acidosis. Hypouricemia and hypophosphatemia are serum findings also seen in Fanconi syndrome. Hypokalemia that worsens with alkaline therapy is typical of proximal RTA and distinguishes it from distal RTA. Also recall that proximal RTA is characterized by a loss of bicarbonate in the urine, which initially results in a urine pH of greater than 5.5. But later, as the plasma bicarbonate levels deplete, and since the distal hydrogen ion secretion from the intercalated cell is intact, urine becomes more acidic, and thus the urine pH measures less than 5.5. Glucosuria, aminoaciduria, and phosphaturia are seen as well due to the failure of reabsorption at the proximal tubule. A negative urine anion gap is seen in proximal RTA because of increased urine chloride concentration. Adequate hydration must be maintained to combat dehydration. Alkali therapy with bicarbonate can also be given to combat acidosis. Potassium citrate can be given for hypokalemia. Also, thiazide diuretics can be added if alkali therapy is not sufficient because thiazides increase hydrogen loss in the urine. For patients with Fanconi syndrome, supplementation with salt, potassium, and phosphate can also be added if required. All right, let's try another question. A 64-year-old female with a past medical history of rheumatoid arthritis was diagnosed with multiple myeloma 4 years ago. Her arterial blood gases show a normal anion gap metabolic acidosis. Which laboratory findings will distinguish type 1 from type 2 renal tubular acidosis in this patient? All right, this patient has rheumatoid arthritis, which is a risk factor for type 1 RTA, and she has multiple myeloma, which is a risk factor for type 2 RTA. Although both type 1 and type 2 RTAs are characterized by hypokalemia, type 1 RTA has a high urine pH, while only the early phase of type 2 RTA has a high urine pH, and this is due to the loss of bicarbonate in the urine. However, when patients seek medical attention, usually in the later phases of type 2 RTA, the plasma bicarbonate levels are already depleted, but urine acidification is still intact. This is why type 2 RTA most commonly presents with a low urine pH. Additionally, multiple myeloma usually causes type 2 RTA in the context of Fanconi syndrome. So on a urinalysis, we would also see aminoaciduria, phosphaturia, and glucosuria, findings which are absent in type 1 RTA patients. Now let's talk about type 3 RTA, also known as mixed renal tubular acidosis. Again, let's begin with the definition. As the name suggests, mixed renal tubular acidosis is a combination of both distal and proximal renal tubular acidosis, and it's a rare type of RTA. The pathophysiology is the combined pathophysiologies of type 1 and type 2 RTAs. Type 3 RTA is characterized by impairments in both bicarbonate reabsorption and distal acidification. It occurs due to carbonic anhydrase 2 enzyme deficiency, and this is a rare autosomal recessive disorder. A mutation in this gene leads to a variety of disease manifestations, one of which is mixed RTA. Patients may present with hypokalemic features such as muscle weakness and ECG changes. It can also be associated with systemic manifestations like osteopetrosis, cerebral calcification, and mental retardation. All right, now let's move on to the diagnosis. In the serum, there are several key manifestations, including hyperchloremic metabolic acidosis, hypokalemia, hypocalcemia, and hypophosphatemia. Changes in the urine include a urinary pH of greater than 5.5 and a positive urine anion gap. The treatment is alkalinization therapy with sodium or potassium citrate. Okay, now let's move on to the last topic, hyperkalemic renal tubular acidosis, or type 4 RTA. Again, let's begin with the definition. Type 4 RTA, or hyperkalemic renal tubular acidosis, is defined as defective functioning of cortical collecting tubules due to either aldosterone deficiency or aldosterone resistance. Recall that aldosterone acts on principal cells and regulates the reabsorption of sodium and the secretion of potassium. The defective collecting ducts causes retention of hydrogen ions and potassium ions, leading to acidosis and hyperkalemia. Notice that the other three types of RTA that we've discussed so far present with hypokalemia and not hyperkalemia. The etiology can be divided into aldosterone deficiency and aldosterone resistance. Let's talk about aldosterone deficiency first. Poorly controlled diabetes mellitus, congenital adrenal hyperplasia, and primary adrenal insufficiency lead to impaired aldosterone synthesis. Other causes of aldosterone deficiency include drugs such as angiotensin inhibitors and angiotensin receptor blockers. On the other hand, aldosterone resistance is seen in pseudohypoaldosteronism type 1, as well as obstructive uropathy. Pseudohypoaldosteronism type 1 is a rare condition which is characterized by mutations leading to aldosterone resistance. Obstructive uropathy causes damage to renal tubules, making them unresponsive to aldosterone. All right, now returning to this image again, let's discuss the pathophysiology of hyperkalemic renal tubular acidosis. Aldosterone acts on the sodium-potassium ATPase pump located on the basolateral membrane of the principal cells, which is responsible for the reabsorption of sodium into the interstitium and the secretion of potassium into the tubular lumen. Then the secreted potassium is partially reabsorbed with the help of the hydrogen-potassium ATPase pump in the type A intercalated cells. An absence of aldosterone or resistance to aldosterone receptors halts the function of the sodium-potassium ATPase pump, which causes potassium to build up, resulting in hyperkalemia. A decreased concentration of potassium in the tubular lumen results in a decreased activity of the hydrogen-potassium ATPase pump in type A intercalated cells. Recall that the hydrogen-potassium ATPase pump secretes a hydrogen ion in exchange for a potassium ion, so decreased activity of the pump results in decreased hydrogen ion secretion. On the other hand, hyperkalemia forces potassium ions to enter the cells, including proximal convoluted tubular cells, and this happens with an exchange of hydrogen ions. Eventually, as hydrogen ions move out of the cell, intracellular pH increases. An increased pH in the proximal convoluted tubular cells inhibits glutaminase, the enzyme that produces ammonia from glutamine. So decreased ammonia synthesis will lead to decreased ammonia excretion in the form of ammonium chloride. All right, moving on to the clinical presentation. Children usually present with impaired growth. Other findings include hyperkalemic features like muscle weakness and ECG changes, such as tall T waves and a prolonged PR interval. Patients may also present with dehydration due to excessive urination. Here is an ECG of a patient with hyperkalemia. A typical feature is the presence of tall T waves in V2, V3, and V4. All right, moving on to the diagnosis. Hyperkalemia is the key finding that differentiates type 4 RTA from all other types of RTAs. Another important serum finding is hyperchloremic metabolic acidosis. Urine findings include a pH less than 5.5 and a positive urine anion gap due to increased sodium ion excretion. Finally, let's talk about the treatment. The treatment is mainly aimed at lowering potassium levels. Hence, furosemide, a potassium-wasting diuretic, can be given. Mineralocorticoid analogs such as fludrocortisone are given to patients with primary adrenal insufficiency. And lastly, patients should be put on a low potassium diet. All right, let's try a question. A 45-year-old male was recently diagnosed with Addison disease. Laboratory workup reveals a potassium of 5.7 and a normal anion gap metabolic acidosis. What is the pathophysiology of this patient's acid-base disturbance? All right, this patient has Addison disease, that is primary adrenal insufficiency with hyperkalemia due to aldosterone deficiency. Additionally, laboratory workup reveals a normal anion gap metabolic acidosis. Given his hypoaldosteronism, his acid-base disturbance is most likely due to a type 4 RTA. So again, let's quickly review the pathophysiology of type 4 RTA. Excessive potassium gets exchanged for hydrogen ions. In other words, potassium enters the cells while hydrogen ions exit the cells. Consequently, increased pH in proximal convoluted tubular cells inhibits glutaminase, which is an enzyme that produces ammonia from glutamine. Decreased ammonia synthesis results in decreased excretion of acid in the form of ammonium chloride. And this is what causes type 4 RTA. All right, here's a nice summary slide that puts together everything we've discussed. So let's review this table and summarize the topic. Distal RTA, or type 1 RTA, is caused by the impairment of hydrogen ion secretion, leading to increased urinary pH of 5.5 or higher, a positive urine anion gap, and a low serum potassium. This can be treated with sodium bicarbonate or sodium citrate. Proximal RTA, or type 2 RTA, is caused by the impairment of bicarbonate ion reabsorption, leading to a decrease in urinary pH to less than 5.5, a negative urine anion gap, and a low serum potassium, and this can be treated with potassium citrate. Mixed RTA, or type 3 RTA, is a rare type and is a combination of distal and proximal RTA with a urinary pH of 5.5 or higher, a positive urine anion gap, and a low serum potassium, and this can be treated with sodium citrate or potassium citrate. Finally, hyperkalemic RTA, or type 4 RTA, is due to aldosterone deficiency or aldosterone resistance. Therefore, this differs from other types of RTA as it presents with a high serum potassium instead of hypokalemia. Urine findings include a pH of less than 5.5 and a positive urine anion gap, and the treatment is furosemide and fludrocortisone. All right, let's wrap up with a final question. A 67-year-old male comes to the physician due to generalized weakness in his extremities. He started feeling weak 1 month ago, and the weakness gradually worsened. He has a past medical history of urothelial bladder carcinoma treated with cisplatin. His laboratory findings reveal a sodium of 140, a potassium of 3, a chloride of 108, a pH of 7.3, a bicarbonate of 20, and a PaCO2 of 36. His urinalysis is significant for a pH of 5, glucosuria, phosphaturia, and aminoaciduria. Which of the following is the most likely diagnosis in this patient? A. Isolated proximal renal tubular acidosis, B. Fanconi syndrome, C. Type 1 renal tubular acidosis, or D. Type 4 renal tubular acidosis. All right, this patient is presenting with weakness, which is likely due to his hypokalemia. He was treated with cisplatin, and now he's presenting with a low pH, a normal PaCO2, and a low bicarbonate, which is consistent with a metabolic acidosis. First, let's find out whether he has a high anion gap or a normal anion gap metabolic acidosis. For this, we subtract the sum of chloride and bicarbonate levels from sodium levels, which in this case is 12. So now we know that he has a normal anion gap, hypokalemic, hyperchloremic metabolic acidosis. We also know that cisplatin is a known cause for type 2 RTA, specifically Fanconi syndrome. Therefore, the correct answer is either option A or B. So how do we differentiate isolated proximal RTA from Fanconi syndrome? Let's recall that Fanconi syndrome is a generalized proximal convoluted tubule reabsorption defect resulting in glucosuria, phosphaturia, and aminoaciduria. All of these findings are present in this patient, so the correct answer is B, Fanconi syndrome. Recall from this slide that cisplatin is one of the many nephrotoxic drugs that can cause Fanconi syndrome. It's known to be toxic to proximal convoluted tubule cells, affecting their overall function. Now let's discuss why options C and D are incorrect. Option C, type 1 RTA, is incorrect because although type 1 RTA is characterized by hypokalemia, it usually has a urine pH of 5.5 or higher. This patient's urine pH is 5. Option D, type 4 RTA, is incorrect because this is characterized by hyperkalemia rather than hypokalemia. So again, the correct answer is B, Fanconi syndrome. And that concludes our lecture on renal tubular acidosis.